The following report contains some disturbing images.
Warning, you could soon lose your job because of what's happening inside this building you see behind me.
Hi, my name is Byron Pitts.
But she's on a study that study with psychology. She's basically.
So virtual people, can you guys hear us?
Yes.
Okay, how about, is there a camera on? Do you guys see us at all?
Yes.
Like a podium camera, or do you see the whole room somehow? See the auditorium, okay. All right, that's probably good. There's, Dominique, is it your computer? There's an echo. Is that something else? I think we're good. Okay, great, awesome. All right, thanks, everybody. We'll get started in just a second. This up.
Okay, can you guys hear me now? I think so. I unmuted it, so it should be okay. Okay, all right. Sorry about that. Okay, let's see. Okay, perfect. Yes. Okay. I'll keep the chat up just in case, because I will play some video. So just make sure that you can hear those two, and just I have the chat box up now in case we need it. Okay, so the outline for today, we're just going to talk briefly, just an overview of the trigeminal autonomic cephalalgias, which I'll refer to as TACs. It's just easier to say, and their suspected and proposed pathophysiology. We'll discuss the diagnostic criteria, pharmacologic treatments, and the non-pharmacologic treatments. We'll talk about a kind of controversial area of research for cluster headache. And then I'll end with a case presentation that of a patient that I saw during fellowship. Okay, so these are considered primary headache disorders. So when we are in headache medicine, we like to make we like to distinguish primary versus secondary headache disorders. So these belong with the migraine type headaches and the tension type headaches. They are unilateral, intense pain that is in the trigeminal distribution, most commonly the V1 distribution, and they have ipsilateral cranial autonomic symptoms. They may share some similarity with the migraine phenotype and even the migraine pathophysiology and some of their therapies used for migraine, but they do represent a distinct set of syndromes and conditions requiring different management at times. They can be difficult to diagnose. They're rare, so this may not be what you initially think of when someone walks into your office. And sometimes you have to use treatment and treatment response to kind of gauge and try to solidify that diagnosis. So they're differentiated between like the main four by their clinical features, their duration, their triggers, and their therapeutic response. So there are four main TACs. So cluster headache, paroxysmal hemicrania, SUNHA, which is the short-lasting unilateral neuralgiform headache with autonomic features, and hemicrania continua. And the SUNHA is kind of the newer terminology that they use, and that includes the Sunken SUNA that you may have heard about in the past. Migraine features may be present, but are often overshadowed by the autonomic features. And what I mean by that is that you may have some nausea, you may have some photophobia, things like that. Autonomic features that may occur include ptosis, meiosis, lacrimation, periorbital edema, rhinorrhea, facial flushing, and oral fullness. And it is important to note that you can, just because you have autonomic features, doesn't mean that it's necessarily a TAC. So you can have some autonomic features with migraine as well. So pathophysiology, sometimes people's favorite topic, sometimes not. But basically what we know about it thus far is, given the relapsing and remitting cycles and sometimes the seasonal relation, the hypothalamus is thought to play a major role in the origination of any TAC. Several animal studies have shown that the hypothalamus, we know, is key in pain modulation, and there are direct connections between the hypothalamus and the trigeminal vascular system. And then the hypothalamus is activated when intracranial pain structures are activated. It secretes, the hypothalamus secretes neuropeptides, orexin A and B, that can have pro and anti-nociceptive effects on the trigeminal system. So it's always kind of that checks and balances. And then PET scans and functional MRIs have demonstrated that there is activation of the posterior hypothalamic gray matter, also known as the midbrain tegmentum, during these TACs. So just to kind of put that all together, here are two illustrations. So step one, you have to be predisposed and have, the anatomy, the genetic makeup to be predisposed to these attacks. So it starts, we believe, in the hypothalamus. And then you get this pain. So you get the vasoactive intestinal peptide and the CGRP that is released. Then you get the cranial parasympathetic activation, which involves the conjunctival injection and flushing, the lacrimation, the rhinorrhea. And then you get the oculosympathetic failure, which can lead to the meiosis and ptosis. So this, I included this little schematic because I don't think it quite as eloquently talks about the steps of the pathophysiology, but I like that it talked about the molecules used and then where the targets for each of the medications that will kind of touch on some of these. So the hypothalamus, it's the target for the verapamil and the lithium that may be used. The cranial autonomic symptoms that you see, it's a target, the vasoactive intestinal peptide, that's a target for the oxygen therapy. That is definitely a testable question. We'll go over that. And then in regards to pain, the CGRP protein is the target for the triptans. So cluster headache, that's the one that I feel like most of us are most familiar with, or at least have read about most commonly. So just a description, it's attacks of severe, strictly unilateral pain, which is orbital, supraorbital, temporal, or any combination of those sites, and it lasts between 15 and 180 minutes. So that's something that could be potentially testable because they like their kind of time course. And it occurs from once every other day up to 8 times a day. And the pain is associated with ipsilateral conjunctival injection, lacrimation, nasal congestion. I won't read all of the symptoms, but you kind of get the gist. This is the description. So I guess I can back up a second. So we use the International Classification of Headache Disorders. It's the ICHD-3. I'm not sure how familiar you guys are with that, but when in doubt, you can go and look for the diagnostic criteria. It's kind of like the headache Bible. So each on this website, there will be a description and diagnostic criteria. Of course, sometimes if you haven't had enough, you can have probable migraine, probable cluster. This is just kind of an aside. But so to fulfill the full diagnostic criteria, you have to have at least 5 attacks. And then this kind of goes over the 15 to 180 minutes. And then either autonomic dysregulation, that's ipsilateral to the headache, and or a sense of restlessness or agitation. So that's another hallmark of cluster headache. They feel so agitated and so uncomfortable that they can't sit still. So cluster headache is the most common trigeminal autonomic cephalalgia. The exact prevalence is unknown, but it's estimated to be about 0.1% in the population. So pretty rare, although some sources say that the 1-year prevalence ranged from 3 to 150 per 100,000. So, you know, it's very testable. It is not extremely common, but it's something that's important to know. The male to female ratio is estimated to be about 3 to 1, so it's more common in males. The age of onset is generally between 20 and 40, and studies have actively demonstrated elevated levels of CGRP, PACAP, and nitric oxide in these patients during clusters. It can be triggered by alcohol and tobacco use, which I'll talk about a little bit more. And then the functional MRI during these clusters demonstrates dysfunction of the ipsilateral posterior hypothalamus. And although it's rare, some cases have been reported where you'll have side switching of the pain. I'm not going to go into this entire illustration, but this cluster headache is one of the most studied, or is the most studied trigeminal autonomic cephalalgia. And this just kind of shows you the different areas of the brain that are altered during an attack or between attacks and in and out of clusters. So again, the hypothalamus is involved. The trigeminal vascular system is involved, and it's just kind of that interplay between the peripheral and the central system. So risk factors, these are kind of debated. There's a family history in 5 to 20% of patients, which isn't nothing. I I can't say, I've seen that, but honestly, I haven't seen a ton of these patients. But there is a subset of patients, 5%, it's estimated, that actually have autosomal dominant cluster headache. Tobacco use, it's noted and reported that 88% of these patients have chronic tobacco use. However, I don't think that that should be thought of as a chicken or an egg situation, because not every person who uses tobacco used chronically has cluster headache. And then there is this questionable head trauma, just because retrospectively, when looking at patients that have cluster headache, a lot of them have experienced some sort of head trauma, but the time course in between the head trauma and the onset of cluster headache is too long. So that's also not thought to be a causal relationship. There's a circadian pattern in about 82% of these patients. And oftentimes with cluster, these occur almost exclusively at night. And there's also a circannual pattern in the spring and the fall. These clusters and bouts are most common. About 25% of patients only had a single cluster. And, hearing about how very painful these are, I would say that they consider themselves lucky. MRI brain with contrast is recommended to rule out any secondary cause, but vessel imaging for cluster. Honestly, on the ped side, if I was seeing a patient that I suspected cluster, and especially if sedation or something like that had to be used, I would go ahead and get vessel imaging. But technically, if you're going by the true guidelines, it's a case-by-case basis for cluster headache. That's a little bit different for some of the other TACs that we'll talk about. Episodic cluster headache occurs in 80 to 90% of the patients with cluster. So that kind of transitions me into episodic versus chronic. I won't belabor all of this, but basically to be episodic, you have to have a cluster from 7 days to 1 year, and it's separated by pain-free remission of greater than or equal to 3 months. I don't think that's going to be testable for you guys. That's more of a headache medicine thing. So I'll kind of skip over that. And then chronic is you don't have that remission period, or you have a remission period lasting for less than 3 months for at least 1 year. And then chronic cluster may arise de novo or transition from episodic cluster. So I chose this slide. If you kind of Google illustrations for cluster headache, this is kind of a famous illustration in the headache community. This is an artist's rendition of how they would describe their own cluster. So it's often referred to as the suicide headache. And one study actually reported that 64 patients with cluster headache had contemplated committing suicide at the time of a cluster attack. And then many have engaged in other self-injurious behaviors. So a good mnemonic to kind of remember for cluster is SEER. So it's single-sided, so that unilateral and or side locked. I mentioned before that technically there are some cases that may switch sides. The E is for excruciating. The A is for agitation. And then the R is for recurrent. Although rare, cases have been reported and suspected in children as young as 2 years of age. I haven't ever seen a case that young. I'm not saying it's impossible. I think it would be truly hard to determine if a 2-year-old, met this criteria, but it's something to at least keep on your radar for me, as a pediatric headache specialist. And then one survey, though, of adults did find that 22% reported some sort of cluster-like symptoms before they reached age 18. So treatment. So for cluster, there are acute treatments, there are transitional and bridge therapies, and there are preventative treatments. So the big one to know for acute treatment, first line is sumatriptan 6 milligrams sub-Q. It's the fastest way to get that in the bloodstream. Zolmitriptan and sumatriptan intranasal, and then the DHE intranasal, particularly Migranal. I don't know how familiar you all are with those, but this is the one. There are 2 intranasal DHEs, and only one of them is currently approved for acute cluster treatment. A big testable is the 100% FiO2. So oxygen is a big testable point. I will say clinically, speaking to my mentors who have tried to get this set up, I don't know if we'll have any better luck in Louisville, but it is often pretty difficult to get someone actual access to high flow oxygen at their home. And it also must be administered via a non-rebreather. So sometimes people will say, well, I tried the oxygen, that didn't work, that did nothing, but it was nasal cannula. So technically you can't count that as a failure. And it has to be for at least 20 minutes. There's a device called technically the brand name is a gamma core, but it's a non-invasive VNS. So it's a vagal nerve stimulator, and it's FDA approved for acute treatment for episodic cluster headache. It's also approved for migraine abortive therapy. And then there's alternative acute therapies include lidocaine. I don't have any personal experience with these, the lidocaine, the capsaicin, the oral ergots, and octreotide. So the point of an acute treatment is to, you have a cluster, they last, up to the 180 minutes, the 15 to 180 minutes. And the acute treatment is to decrease the time of that particular single attack within that cluster. It doesn't shorten the cluster itself. And it is noted that if you have someone who is needle averse with cluster or has failed the injectable sumatriptan, you give the nasal sumatriptan in the contralateral nostril if there's rhinorrhea or congestion, nasal congestion, just to kind of help that, make sure it gets there. The transitional and bridge therapies, these are intended to hasten the resolution of the current cluster or bout. So sometimes people will try oral prednisone for 5 days with a taper, and occipital nerve blocks with or without steroid. You can use oral ergots as well, but I didn't find as much research or reported for that to be as beneficial. Then for preventative treatment and maintenance treatment, verapamil is first line. You need a baseline EKG because you're at risk for PR, prolongation, and heart block. And that's often given in combination with glucocorticoids just due to the kind of slow titration of the verapamil. You can try lithium and topiramate, second line. And then there are a few other preventatives listed. Like I said, not everybody responds to the first line medication. So sometimes you're looking for these other ones. Galcanezumab, which is one of the CGRPs, is Emgality. This, in my clinical experience, when I have had adult patients when I've been rotating through those clinics, this has been really reported as a game changer for these patients. The 300 milligrams, it's 3 100 milligram syringes given at the start of a cluster period, and then monthly for as long as that cluster lasts. You can also use a gamma core for prevention as well. Surgical interventions, disclaimer, I have no experience for the use of these in cluster headache, but I know at bigger centers, some of these are used. So I'd love to hear at the end if anybody has any experience or any thoughts about these. So I'm not endorsing these, but I just, am kind of mentioning that these are in the literature. So an SPG stimulator, which is not currently available in the US, an actual VNS, a DBS, or an ONS. You can kind of taper these preventative and prophylactic medications after the cluster ends, and then kind of restart them again. So this is a debated topic, and I don't endorse this. So that's kind of my disclaimer, at this moment. But there is an active area of research looking at psychedelics and cluster headache. And one study analyzed comments from cluster headache patients that revealed that 35.5%, and those are of the patients that are actually reporting and endorsing this, have tried psilocybin, LSD, cocaine, and MDMA. It's actually such a popular treatment among patients that the AAN kind of is looking a little bit at this to kind of make a statement. There is an advocacy group called the Cluster Busters that has reported with their patients the use of psychedelics. Not only report their patients not only report effective treatment, but then they also have less attack PTSD. They also report that the patients that they have using it use far less of a dosing than recreational doses. So they report what they call a 2-beer buzz, and generally nothing more significant. However, the DEA is not currently endorsing this idea, and neither is the AAN, but this is an active area of research. And from this paper, I took a few of the quotes that I found were quite interesting. Me personally, I've never had a cluster headache, and I hope I never do, but it really makes you feel for some of these patients. Okay, so this person, they have gone to crack cocaine, which helps. They've also have tried LSD, they've tried shrooms. This person had good success with magic mushrooms. This person said that you will eat shoe polish if you think it will help. You will just try anything. And this person felt that the psilocybin is a life changer and has really helped them, change their quality of life. Again, I'm not personally endorsing this. I'm just kind of like letting this know and trying to, kind of keep things interesting for you guys. Okay, so let me see. I have a video that talks about cluster. Let me move. Oh, shoot.
West Louisville's getting the first new hospital in 150 years. I'm gonna vote for Andy Bashir. He showed up for us.
Can you guys hear it on Zoom?
The following report contains
Yes.
Okay, great.
images.
It is one of the most painful experiences that a human can endure.
It feels as though somebody is grabbing your inside of your face and pulling as far out and as far wide as they can.
Difficult to watch, often unbearable to experience. The pain of a cluster headache can be indescribable. Some sufferers post videos showing an attack to try and convey the reality. We're using these with their permission. Scott has suffered them for 10 years. He helps run a support group, Ouch UK.
I have knocked myself out on various occasions because of the pain. I will find something very, very hard to strike my head against, and because you're driven, it's a primeval driver to stop the pain.
Cluster headaches baffle doctors. Far more intense than a migraine, many sufferers, like Rachel, experience them when seasons change.
I will get mine every spring and every autumn without fail.
Rachel's volunteered for a new research project taking place at King's College Hospital in South London.
So we're looking to see what happens in the brain during the attacks compared to when there is no attack.
Around 40 sufferers will have their brains scanned.
This is the posterior hypothalamus, and it's also known as the internal body clock. We think that is linked with the cluster headache attacks. They tend to have more cluster attacks around spring and autumn. We don't quite understand the reason behind that.
This will be an ambitious, at times arduous project. Volunteers will also be having their brains scanned whilst an attack is taking place.
Unless people put themselves forward to things like this, we're never going to know any more about cluster headaches.
It's estimated there are around 130,000 sufferers in the UK, possibly more as the condition is often misdiagnosed. This patient, who's asked to remain anonymous, is being injected with steroids and an anaesthetic, a preventative measure that can help, but is only effective for a few weeks.
It's supposed to damp down the activity of the nerves, hence give some relief to these patients.
It's hoped this device, which would be implanted inside a patient's head, could offer long-term help.
The way it does is by delivering some electricity around the nerve and damping down the hyperactivity, the excessive activation of the nerves, which is firing without any control.
Trials are going well. The team at Guy's and St Thomas's Hospital.
Okay. So I wanted to include that, one, to just kind of show you, there we go, kind of what a patient looks like during an attack, two, just to kind of mention again the posterior hypothalamus and the kind of circannual and kind of seasonal periodicity of cluster headache. Okay, so switching gears, paroxysmal hemicrania is our second TAC. Attacks of severe strictly unilateral pain, which is orbital. You know, I'm not going to read all of this for you. Again, lasting 2 to 30 minutes and occurring several or many times a day. They can have the autonomic, they need to have at least one autonomic finding, and they respond absolutely to indomethacin. So that's why this one is so important, because it can be a game changer for these patients. Technically, to be diagnosed by the ICHD-3 criteria, you have to have had at least 20 attacks. Again, 2 to 30 minutes, so shorter than cluster headache. And you know, you get autonomic findings, and again, the sense of restlessness or agitation occurring with a frequency of greater than 5 per day, but prevented absolutely by therapeutic doses of indomethacin. So this makes up about 5% of all of the trigeminal autonomic cephalalgias. The sex ratio, male to female, 1 to 2 to 1 to 3, but it's certainly more common to be chronic in females more than males. The onset is typically when a person is 40s to 50s, but case reports show a very wide range, especially as we start recognizing this more. Studies have demonstrated elevated proteins, including CGRP, in patients with PH, and it may be triggered by neck movement. So that's a little bit different, but paroxysmal hemicrania in particular may be triggered by these neck movements. About 80% of PH is chronic, and it's hypothesized to have, you know, that similar pathophysiology of that dysfunction in the hypothalamus. However, functional MRIs demonstrate the dysfunction of the contralateral hypothalamus instead of the ipsilateral hypothalamus, like in cluster headache. To be episodic, similarly, to about 7 days to 1 year, and separated by a pain-free remission period of 3 months. So we're getting kind of a pattern here. And then this one is without a remission period, or with remissions lasting less than 3 months for at least 1 year. Indomethacin is, you know, it's absolutely responsive to indomethacin. So it's generally started at 25 milligrams 3 times a day for 3 days, and increased to 50 milligrams TID for 3 days, and then increase further if needed. The mean effective daily dose from the cohort studied have shown around 150 milligrams total daily to be an effective treatment. The treatment is typically continued for 3 to 6 months after symptom control. Of course, it's recommended that you start GI prophylaxis, because indomethacin can be quite harsh on the stomach, and the preferred PPI for this is pantoprazole. There is some weak evidence that also shows that treating with melatonin or Boswellia serrata can be helpful, but we know the response for indomethacin is better. However, if there's somebody who can absolutely not tolerate the indomethacin, those would be supplements to potentially try. Other treatments include the COX-2 inhibitors, verapamil, topiramate, nerve blocks, et cetera, et cetera. I talked a little bit about it in children. So it's not well established. During a chart review, 5 patients, which was 1.3% met, or the total 5 patients, and then the probable criteria, it was 1.3%. And another source estimated the prevalence to be 1 in 25,000 compared to cluster headache, which could be up to 1 in 500. There's a wide range reported, even thought to be as early as 1 year of age. The first reported pediatric case was in 1989, and it was in a 9-year-old boy. The average age of onset for peds could be 6.5, with the age of diagnosis 8.2. So if you think about that, that's a long time to kind of deal with this condition. Restlessness and autonomic features can be more challenging to recognize in younger patients, especially when they can't fully describe to you what they are feeling. And one review found a boy to girl ratio of 1.5 to 1. In terms of, family history and other risk factors, there was a review of 38 cases, and there was no family history of anything like PH. However, breath holding spells, bipolar disorder, migraine, and then unspecified headache were reported in those patients. It's unclear why, but left-sided head pain was almost twice as common as right-sided head pain. I'm not really sure if anybody has any ideas on that. I'd love to hear your thoughts. And then almost all cases reviewed responded completely to indomethacin. However, some required topiramate and sumatriptan, sodium valproate, or verapamil in addition to indomethacin. So then we have the short-lasting unilateral neuralgia form headache attacks, the SUNHA. Again, strictly unilateral head pain, seconds to minutes. So, getting really short there, occurring at least once a day, and usually associated with prominent lacrimation and redness of the ipsilateral eye. Here's our diagnostic criteria. So you have to have at least 20 attacks. Moderate or severe unilateral head pain, you get the cranial autonomic symptoms, and occurring with a frequency of at least 1 per day. And it can be these, one thing that they kind of talk about with these, so at the time I kind of skipped over that, is 1 to 600 seconds. And it can be single stabs, a series of stabs, or a sawtooth pattern of stabs. And this is just kind of a little schematic that was in a review article with these. So single stabs, group of stabs, sawtooth pattern. They are, SUNHA is further separated into SUNCT. So that one, it's SUNHA, but it has both of the following: conjunctival injection and lacrimation. Again, you can have episodic and chronic. I'll kind of skip over that. And then SUNA, you just don't have both of those to be SUNA. So I don't know how long this true distinction will be in the headache world, but it's something to kind of consider and just to at least know. I don't know how testable that is for you guys, more testable for me. So the prevalence is unknown. Male to female, it looks the studies, they suggest 1.5 to 1. The onset is 40s to 70s, and majority are chronic. The pathophysiology is hypothesized to involve the irritation from the trigeminal nerve and the hypothalamic dysfunction. So again, similar to that dysregulation. Imaging is needed though for SUNCT and SUNA to assess for a vascular loop compression or pituitary pathology. So this is the one that I would definitely get vessel imaging for as well. And then similarly to trigeminal neuralgia, SUNHA may be triggered by touch or temperature. So that's something to keep in mind for that. Functional MRI doesn't really show a consistent pattern. So sometimes it's the contralateral, sometimes it's the ipsilateral hypothalamus showing dysfunction. Treatment for SUNHA, they're so short that there is no acute or abortive treatment for these. It's 1 to 600 seconds. So by the time you took something, even a sub-Q sumatriptan wouldn't get in your system if it's less than 10 minutes most likely. So lamotrigine has the best evidence, but sometimes they'll use oxcarb, topiramate, duloxetine, carbamazepine, some similar trigeminal neuralgia medications. Steroids can sometimes be used for relief. Nerve blocks are sometimes used, and for extremely refractory cases, IV lidocaine. I personally haven't been involved in a case that's had to use that, I haven't really heard a lot about those. So that was kind of me really digging through some of the articles. So our last one, I'm trying to be conscientious of time. Our last one is hemicrania continua. So similar to paroxysmal hemicrania, given that it is absolutely sensitive and responsive to indomethacin. However, the time course is different. So this is present for greater than 3 months, and you often have exacerbations of moderate or greater intensity. So sometimes people will describe this, this baseline pain level with these superimposed, either stabs or superimposed exacerbations for these patients. So they have at least one of the autonomic findings, or they may, and they can have a sense of restlessness or agitation or aggravation of the pain by movement. So they may feel restless, but they may, not want to move because it might hurt worse. There can be a remitting and unremitting subtype. I'm not going to go through all of that. The actual prevalence is unknown. There's only around 1,000 published cases of hemicrania continua, and the cases have been published from the first decade of life to the 8th decade of life. Although it often presents in a patient's 40s to 60s. Patients will also often complain of a foreign body sensation of their eye, their ipsilateral eye, and stabbing pains can be common. Functional MRI shows contralateral hypothalamic activation and ipsilateral dorsal rostral pons activation. The pain is most often anterior and temporal, the pain of the headache itself, but it may also occur in the occiput. And then there's constant unilateral baseline pain with those superimposed tacks, like I mentioned before, and they may have prominent migrainous features. Again, treatment, indomethacin generally started and increased. Interestingly, and then again, some of the other treatments, interestingly, being at various headache meetings and just kind of speaking to mentors about patients that they have taken care of with hemicrania continua, and how long do you continue this indomethacin treatment? And there are some patients, I don't know what Dr. Soul's thoughts are, but some patients stay on indomethacin indefinitely because they otherwise will kind of relapse back into this pattern. So that's kind of a topic of debate. This is a good take-home table for those that are going to be tested. This really breaks it down. This is from a good review article. It talks about the times, the attack frequency, the sex ratios, and the major treatments. So this is a good testable table. This is a schematic that again just kind of hammers home the fact that Soon-Ha is the shortest, and it can be up to hundreds of times per day, and then hemicrania continua, of course, is the longest. So I am going to finish up with a clinical case that I saw in fellowship. So 15-year-old presented to headache clinic. It was one of my mentors' clinics that I was rotating in with complaint of severe headache for 6 months that was associated with loss of vision in her left eye and the inability to hear in her left ear. Her headaches occurred multiple times a day and were worse at night, but could occur any time of day. The average duration was an hour, but they range from 30 minutes to 9 hours. And then the pain was severe and located in the left temporal region behind her left eye. So, headache medicine, we like to ask a lot of questions. So we had to get, some more information on this, because at this point, it sounds like it could be a few things, or even potentially migraine. So the pain was throbbing and squeezing. She further described her pain as like, my brain is trying to come out of my head and it feels hot, like it is about to catch on fire. She endorsed phonophobia, nausea, vomiting, loss of vision in the left eye, but when you kind of try to suss that out, it wasn't true loss of vision. It was this blurring of vision in her left eye. Loss of hearing in her left ear. That wasn't true loss of hearing. It was ringing in her left ear. And then tingling in her fingers and toes on the right side, and some dizziness. All symptoms occur during her headache. And she reported feeling very agitated, but feeling like it would be better if she sat still. So she had that inner restlessness, but she wanted to hold still. So the frequency gradually progressed and had been multiple times per day for 4 months. And she endorsed a constant level of head pain in that distribution of about a 1 to 2 out of 10, with multiple episodes of exacerbation to severe pain up to a 9 or 10 out of 10 throughout the day. She was currently treating with ibuprofen 800 milligrams twice daily for the last 3 to 4 months. And she notes improvement, but it doesn't take her head pain completely away. Her physical exam was completely normal. So based off of her symptoms, we feel like she met the criteria for hemicrania continua and medication overuse headache. Medication overuse headache, there's different schools of thought for in the headache community. I'm happy to debate that with you at some point if you so desire, but that's what we thought at that point. MRI was ordered to rule out any structural pathology, and her results were completely normal. She was started on indomethacin 25 milligram tablets and given a titration schedule to go up to TID, and the pantoprazole for GI prophylaxis, and given Zofran for her nausea. So here's a case where we had hemicrania continua, but also had some migrainous type features as well. So they did a phone check-in 2 weeks after her appointment with an update. Episodes had improved, but had not stopped. So we increased her dose up to 50 milligrams TID. And if you remember the cohort, the average total indomethacin dose from the cohort that I reported was 150 milligrams daily total. And she reported that her episodes of severe eye pain had resolved, but she had continued to have some episodes of some changes in hearing and changes in vision and tingling, and now having headaches that had transitioned a little bit more to this frontal and throbbing. So initially she no-showed for a follow-up appointment, but did eventually come back. And at that time, her headaches and head pain had completely resolved. However, she still had some autonomic dysregulation. She ended up being at that time at a dose of 75 milligrams, 50 and 75, and then she remained on the pantoprazole. But she was kind of left with this constant, headaches had completely resolved, especially the superimposed headaches. She did have a little bit of pain here and there, but it was a significant difference for her than what she came in with. And she was somewhat tricky. She was, I feel like sometimes these patients have seen, by the time they get to you, they may have seen many different doctors, so they're almost defensive in the beginning. They feel like you're not going to leave them and things like this. And this was a completely, she was debilitated by this and not doing well in school and not being able to go to school some. And this really was a positive impact on her. So I thought that was an interesting case to present. I do have one other quick video, if we can do that. Just kind of a public figures.
My name is Byron
experience.
I'm the co-anchor of Nightline for ABC News. I've been a professional journalist for more than 40 years, and I've struggled with severe headache pain most of my life. For the longest time, I thought, it's hereditary, deal with it. My mother suffered severely with migraines. A bad episode meant she'd stay in bed in the dark in her bedroom for days on end. By my mid-20s, that was my go-to treatment plan. I thought I'd simply have to suffer in silence like my mom. I can remember when family or friends would ask, what's wrong? And I'd say, I'm having a migraine. The most common response was, oh, thank God it's nothing more serious. Serious. At best, my migraines were emotionally and physically exhausting. The slow drumbeat of pain behind my left eye was debilitating, but the fear I felt, the sadness that overcame me as the pain worsened, would often send me into a deep depression. Over the years, I'd ask my primary care doctors for help. They'd suggest brain scans, a visit to the dentist, the eye doctor, etc. I was left wondering, do I have headaches or is a stroke brewing? Finally, by my mid-40s, I'd reached a crossroads. My career was going well, but my migraines were becoming more frequent and more painful. I wasn't even sure how much longer I could keep working. Sure. Last time I was living and working in New York City, and a colleague recommended I go see a migraine specialist.
His eyes are asymmetrical.
They are. Mm-hmm. Mm-hmm. Very good observation.
A what? I wondered. After so many years, I didn't know such people existed. So much for a career in journalism. If I had limited access to information, what might life be like for others? So I finally made an appointment, and I don't say this lightly. My physician, a headache specialist, didn't simply change my life, he saved it. Based on his diagnosis, I didn't have migraines. I suffer with cluster headaches. The medications he prescribed have made my condition manageable. I no longer feel my cluster headaches. I know now it's treatable.
Okay, so just in the interest of time. So basically, a journalist, you heard that he had been, thought that he was dealing with migraine, actually dealt with cluster, and once it was managed appropriately, was life-changing to him. But very good observation that he has left-sided ptosis. Okay, so I'm almost finished, I promise. So conclusion, so it's important to recognize these so that you can choose an effective treatment. Remember, if you have paroxysmal hemicrania or hemicrania continua, that they generally, by definition, they absolutely respond to indomethacin, so that's something to keep in mind, and you can really improve a patient's quality of life. Currently, still recommended that all patients have imaging if there is a suspected new onset trigeminal autonomic cephalalgia. I'll be interested to see how the CGRP future research, how that goes with other treatments for the tax. And just, it's important that we kind of spread the awareness, but there's still lots to learn for the tax. So we have a few minutes. I'll do my best to answer any questions if there are any.
Thank you.
You're welcome.
It's a great overview, Rachel. So you mentioned this fellow. So I have a fellow that has followed me for 20 years, and I only see him every 2 or 3 years. He's in his 70s now. I first picked up after 40s or something. Similar story. So he was diagnosed with migraine, lived in rural Kentucky, received migraine treatments. Effective. Probably just did 100% oxygen at the time. That got initially. Yeah, so he's got episodic cluster in response to the 100% oxygen. Cluster is not something that you see as common at all.
Right.
Probably 2 a month, something like that. And they were followed. It is curious that with the hypothalamic involvement, which has been well worked out, one cannot experience one other person's pain, but why is the pain so much worse than other headache types?
Right.
And I don't know if that's, who knows what's psychological or not, but essentially the attacks come on very sharp, very abrupt, and predominantly occur at night. And so I don't know, so the patients come in, they're just all worn out because not just from the pain, but the disruption of their usual lifestyle. So,
right.
It's a very good presentation.
Thank you. Thank you. I know, and nobody is going to expect, everybody to diagnose these, immediately. Our patients don't read our textbooks, unfortunately. So it's not always a clear diagnosis, but it, with time and perseverance, you can sometimes get there, and it is pretty rewarding. So there's some questions in the chat. So is it possible to obtain serum CGRP levels clinically? To my knowledge, that is just being used for research purposes at this time. I don't know, and Dr. Soul's shaking his head.
I don't think the insurance would pay for it, but they're certainly used in a research manner. And so even the triptans have been demonstrated to lower CGRP levels.
Mm-hmm.
Levels are elevated during the attack.
Mm-hmm.
But they're not yet used to
Sure.
Why is oxygen therapy effective?
So, and that was also Dr. Dahl's question in the chat. So I was going to bring, this, am I still sharing? So, I don't know if you know any better than I do. So it is my greatest understanding is that the oxygen is the target for the superior salivatory nucleus, and that kind of can counteract a little bit of that vasoactive intestinal peptide. So
that's my understanding too. I don't think there's any kind of direct effect on our knowledge in terms of vascular reactivity or anything like that.
Mm-hmm.
Supplemental oxygen will cause vasodilation.
Mm-hmm.
Any other vasodilators are effective?
The calcium channel, because you get a little bit of the vasodilation with a calcium channel blocker. In terms of other like true vasodilators, not to my knowledge. I don't.
Not to my knowledge either. I mean, there's active research looking at nitric oxide. You mentioned the CAP, which is pituitary adenylate cyclase.
Adenyl cyclase, yeah.
So it's a protein that is involved, but yeah, I don't really think that we understand oxygen at all. But it's been used for years and years and years and years and years. Only recently have there been studies showing that maybe the non-rebreather is superior to just the face mask at high flow. And then, 10, 15 years ago, there were studies comparing. For years it was 7 liters per minute.
Bumped it.
10 to 15.
Yeah, 12 to 15 now.
So it's an area of active research.
So the role of the CGRP receptor transmitter system is lately, there's some enthusiasm for the CCK, the cholecystokinin receptor, evidently becomes upregulated in the conversion of acute chronic. I'm not sure whether this muscle is active long enough to experience a conversion like that. But the one drug, I mean, there are probably a whole host of now peptide analogs that are going to come on the market for CCK blocking and various subtypes of CCK. So that may have some role. And then the other thing that is immediately available is that oddly, the benzodiazepines are mild CCK blockers. So some of the responses that people use to get to Valium may actually have a basis, with the chronic pain. We've gotten so negative about benzodiazepines that we have, I would say, I've certainly experienced an era of dismissiveness to even trying it. But I do remember in my early days when we would occasionally use it, that people reported some improvement with it on the chronic pain. So I'm not sure where that might fit in eventually, but it's interesting that all these gut transmitters are, everything that's in the brain is also in the gut.
I know.
I wouldn't be surprised come up with one that is uniquely involved here. But I guess it's too much to ask, like Parkinson's and dopamine and whether Alzheimer's, acetylcholine, there are efforts to make a neat periodic table, if you will, of the pain and the transmitter, and there's so many of them now.
Right.
But for every signaling system, there's an excess syndrome and a deficit. I wouldn't be surprised that eventually you're going to find something. The other thing we did when I was in Toronto with the really worst cases, we would do a superficial control directive.
Really?
And you can do that to superficial control nerve. The greater superficial control is the parasympathetic contributor to the video nerve, which is going to the sphenopalatine ganglion. So we would, I was a resident, I just drove the trucks, but I was trained to do this operation where we would make an opening onto the flush with the roof of the petrous pump. We would elevate the dura just off and then find where the greater superficial control comes out of the middle ear area and then runs anteromedial to the cavernous sinus to join up with the sympathetics to make the Davidian nerve. And so we would interrupt that nerve, and many of these autonomic features got better. I guess you can't sweat without certain
right.
But and at least some of these patients that I saw post were reporting improvement, but then they have cluster periods anyway.
Mm-hmm.
So I can't speak to it as a really effective treatment. But that, you're not aware that that's gone anywhere because.
No, I haven't seen that. At least when researching this in terms of surgical interventions, the ones that I saw were like the DBS, the VNS, and kind of things like that. But no, that's really interesting. And I didn't see a ton of, I know in our clinic, like needleless, we would do needleless SPG blocks for status migrainosis. So we wouldn't even, do with the needle and that sort of thing. So I didn't even see a ton of, the done under fluoroscopy or landmark with needle SPG blocks used. But I mean, the SPG is certainly involved.
I think Kim Meyer has developed a minor practice in greater superficial. I'm sorry, in the sphenopalatine ganglion.
Oh, okay.
And I've seen a patient or two that was singing her praises, but when you have something that gets worse and gets better, it's hard to establish causal relation.
Yeah, I think the SPG device that you mentioned was intriguing. There was a big body of research like 10 years ago.
Mm-hmm.
And so it was Autonomic Technologies Inc. I think was the name of the company that actually did the device. And they were implanted over the SPG ganglion, so the sphenopalatine ganglion, which is mainly B1 and B2. And their data showed a significant reduction in not only halting an attack, but then reducing the number of attacks. So it's sort of preventive as well for cluster. But I don't know what happened. I don't know where that went.
Interesting.
But it's, I think they were mainly inserted by ENT surgeons, but it was intriguing because it would restore control, restore the locus of control to the patient, right? Because they would hold the remote control that would shut off their cluster attacks, which is intriguing.
That is really interesting.
Thank you for a great presentation.
Yeah, no problem. Thanks for having me.